Thank you. I'd just like to say thank you, first of all, for the opportunity to come and speak today. I guess the story I've got to tell is going to be in contrast to what you've just heard from Susan. I'm going to be talking about how we do this in a sector of the healthcare system that is somewhat, at least in my opinion, lagging significantly behind and has I guess, without hopefully sounding too harsh, ridden sort of on the coattails of what's been done in the public sector, and there's still a lot of work to do. So a little bit about where I'm from. So that's a picture of the front part of our hospital. I was going to talk about how transparent we are in our hospital because we have no roof, no walls, and no windows. But in fact, it is a 200-bed acute medical and surgical hospital with an emergency department and an intensive care unit, and it's a busy place. I guess I've got to work out which way this goes now. That way, there we go. So I guess I should just start really the discussion with, well, you know, what about the private system in this country? You know, is it a small-time player? Is it a big-time player? Where does it actually sit? And does the work that is done in the private sector actually matter? Well, I think that the evidence says that it does indeed matter. In the 2012-13 financial year, 2 in 5 hospitalisations in this country occurred in the private sector. 2 in 3 elective surgeries occurred in the private sector. 3 in 5 acute surgeries as defined by the need for surgery within 24 hours. More than 45% of chemotherapy services. More than 70% of eye surgery and almost half of all cardiac surgery is done in the private sector. So it's a significant volume of work. One of the problems is that it doesn't enjoy necessarily the same level of sort of executive support that perhaps the public sector enjoys. Despite that significant activity, fortunately, at least from the references I could find, there are fewer adverse events reported in the private sector, with 4.1 versus 6.7% of separations. So what's attractive about it? Why is this volume of work done in the private sector? What actually, you know, what is it that attracts doctors to go and work, you know, and practice their craft in the context, in the setting of a private hospital? How do they actually view their role within that hospital? And what level of scrutiny does their performance actually receive? So I think the answer to the first question, for those of you who already do a significant amount of work in the private sector, you may have, you know, certainly more than what I'm about to say. But I guess in a nutshell, the big ones would be, first of all, a sense of autonomy. There is that sense that you're more autonomous with your work. There are fewer layers of bureaucracy to have to sort of get through in order to practice your wares, and the sense that you can practice your craft in a fairly unimpeded way. The next one is efficiency. Most of my colleagues do report a greater sense of efficiency working in our hospital compared to in the private sector. The third one, I guess, is we can't, you know, miss the elephant in the room, and that's remuneration. That's obviously a big driving factor with doctors with the right to private practice in general earning about 27% more than their colleagues who don't have it. And obviously that can be even higher depending on the amount of work that's, the percentage of your work that's actually done in the private sector. So I thought we'd just explore the sort of relationship between the doctor and the private hospital. And we talk about an informal mindset, the VMO mindset. So historically, in exchange for providing the hospital with a steady stream of patients, and hence a steady stream of revenue, there's an expectation, as I said, of greater autonomy, efficiency and entitlement. That's led to a few problems, I think, a few challenges, I should say. One of the big challenges is that both the doctor and the hospital have really regarded performance assessment as being a personal thing rather than something that is driven by the hospital itself. So typically hospitals have left the whole discussion, the whole concept of performance appraisal up to the various doctors. And they've been heavily reliant, I think, on the processes that occur without their hospital, such as all the things that Susan was talking about in her talk. A lot of the VMOs have co-appointments, so they're appointed in public sector and would undergo, hopefully, the sorts of processes that Susan has just outlined. And I think that the private sector often relies on this. There are some fundamental problems with that, which we'll talk about shortly. The other thing is that really, if you're a doctor working in the private sector, there's really this sense that you're a bit of an entrepreneur, that you're working for yourself, your work generates your income, and it almost occurs in isolation to any of your colleagues in many ways. And I think the problem with that is that tends to lead to this concept of perhaps that you don't have to, or you either willingly or inadvertently aren't subject to peer review. So how have we traditionally done this? This isn't one of the surgeons at our hospital, by the way. Yeah, he wouldn't be holding the scissors. Our traditional approach really has been mandated or sort of driven by our bylaws and code of conduct. Now, our bylaws and code of conduct are fairly strong in that they don't tolerate poor behaviour and poor performance, but the degree to which they've been applied over the years has been quite variable. And once again, it comes back to the problem that the VMOs are not employees of the hospital. I think that's a fundamentally important concept. They're not employees of the hospital. They're actually separate to that. They're external. And so there's this relationship between the hospital and the doctor. And really, fundamentally, there are two relationships. There's the clinical relationship, whereby the hospital provides a safe and secure environment for the doctors to practice their craft. But there's also the business relationship. And that's a really important one because private hospitals receive their funding. So we should ask the question, who are actually the customers of the hospital? It's not the patient, it's the VMO. And so anything that traditionally the hospitals have been very hesitant to damage that relationship for good reasons. Traditionally we've relied on bylaws, we've relied on self-audit and fulfilment of college CPD requirements, and that's certainly part of our ongoing re-accreditation process, is to ensure that at least you've fulfilled your college CPD requirements. And we've traditionally focused on addressing episodes of poor performance and behaviour rather than necessarily encouraging good performance and behaviour. So it's not that we don't do anything, we actually do a lot of work in this field, but it's just that we traditionally wait till a problem arises and then we respond. And there's a lot of trust placed by the hospital onto the shoulders of the doctor. We're trusting that they will be professional, that they will be competent. All the things that we've been talking about earlier today are actually put to the test in a big way in this environment. However, the landscape is definitely evolving. That's Yosemite Valley for anyone who doesn't know. It's a beautiful place, and I couldn't find a better landscape picture. I thought it was. So in what way is the landscape evolving? Well, private hospitals, as public hospitals, have to subject themselves to regular accreditation, and we're accredited by the Australian Council of Healthcare Services via their national standards, and that happens every 3 years with a sort of a smaller accreditation occurring at the 18-month mark. Part of the national standards now is the expectation to link accreditation or re-accreditation to peer review. So we have to demonstrate that before we re-accredit a doctor to our service, our hospital, that there is evidence of peer review. Where they exist, our surgeons who operate in certain areas have to be involved with national registers, and the two best examples would be bariatric and breast surgery. And we've just had a new set of bylaws come into effect in October last year that actually now requires the formation of clinical groups or clinical craft groups, which I'll talk more about in a moment. There's also the ubiquitous My Hospital's website, so the public can, and increasingly private hospitals are now, the data is now present on this website. So a patient can get on the website, have a look at the hospital they want to go to, and look at it, see what its infection rate's like, see what its, see what if there have been any mishaps, what would appear to be systemic problems. But fundamentally, the biggest change in the landscape has been the relationship between the private hospital and the private health insurers. This is a rapidly changing area, and effectively there's been a significant tightening of expectation by the health insurers. They are auditing. Medibank Private pretty much audits every patient's record that comes. Every patient that comes to us, they'll audit. They employ thousands of people to audit records, to try to limit the amount that they actually pay the hospitals. And some might say that that's a knee-jerk reaction or excessive, but I would probably do the same if I was Medibank Private, to be perfectly honest. I want to be ensuring that I'm actually paying for good quality healthcare. So what happens if they make a determination that the healthcare that was provided wasn't of good quality? Well, quite simply, the hospital doesn't get paid. The doctor still gets paid, but the hospital doesn't get paid. That's a risk for the hospital. Especially if the poor service has occurred as a result of poor clinician performance. So rather than take the fight up with, for example, unexpected return to theatre due to a post-operative bleed or something like that, rather than actually take that discussion, rather than the health funds actually take that discussion to the surgeon, they'll actually ask the hospital, they'll actually blame the hospital for that. And it's the hospital's job now to sort it out with the surgeon. So, like it or not, private hospitals are now forced to look at performance with a lot more vigour than they perhaps have been accustomed to. Okay, thank you. So how do we do it now? We have certainly better, closer communication between the hospital executive and the VMOs, and we try to foster just regular meetings so that everyone's on the same page and everyone understands what the insurers are up to and the games they play and exactly where we're headed. There's certainly an acknowledgement that private hospitals have a duty to ensure quality and safety, and that's an acknowledgement from the clinicians. What do we now expect? We certainly are much tougher than we were with compliance with the bylaws. We really, particularly with regard to code of conduct. So we are in the process of trying to, despite the fact that it could potentially harm our business relationship, we really are trying to crack down on poor behaviour, change. The culture hasn't been bad in our hospital by any means, but there's always, it's the same for everywhere really. You want no bad behaviour. We audit the same sort of KPIs that pretty much most other hospitals would do: length of stay, unplanned returns to theatre, unplanned or unexpected readmissions, and reportable infections and sentinel events. And we take those figures to the surgeons. We've established, as I said before, I say it was a faux pas, surgeons as opposed to, we are predominantly a surgical hospital. Establishment of clinical craft groups and craft group meetings, and a lot of the VMOs have said, well, why should I do this? I think this is a really important point. Why should I do this when I already do, have meetings like this in the public hospital sector? Well, unfortunately, we don't know that you've done it in the public sector a lot of the time. We don't know what your confidential performance report was. What we know is that you're working in this hospital on patients that we have to take responsibility for as well. So I'm sorry, we have to do it ourselves. And it's met with some resistance, but gradually, the majority of people think that it's actually a good idea. And that is, Also, just briefly, if you consider that we now have an increasing number of doctors who work exclusively in the private system and don't do any public work, so they're not subject to any form of peer review other than what we provide. And we also have strong VMO involvement on some of our important committees, particularly our Patient Care Review Committee and Scope of Practice Committee, so rather than a DMS saying to somebody what you did with that patient was perhaps a bit suboptimal, it's actually a Patient Care Review Committee that's comprised of their peers that are actually saying this now. So we think that that's been a step in the right direction. So I'll finish off there, but hopefully at the end of it, everyone's happy. Yeah, so a slightly different scenario to what we've heard so far.